Hello, good evening. Welcome back to my MVF&x and the European Fertility Society. We are happy to be back once again right here with you. Please let us know if you can hear us and see us. We want to make sure that everyone is able to hear us properly. And we are joined today by Dr. Esther Marban, as you can see her right here. I'm really happy to have you back. We already discussed, we already talked about when was the last time we seen you here, and I think it was more or less in October. So I'm really
Something like
happy
that.
that you are back with us. I'm sure it's going to be a great session. Our topic is focused on fertility for women over 40. So as you know, it's a tough topic. I'm really happy that we are again introducing this because this is a topic that we are discussing, let's say, every now and then, as we know that this is the topic that you definitely want to want us to explore, and I'm sure you will have lots of questions as well. So please remember that we will start with our presentation where Dr. Marban will explain all available options, and afterwards there will be time for your questions. So please put those questions in the chat. You can do it right now, you can do it during the presentation or afterwards, and Dr. Marban will definitely answer those for you. Remember, it's all anonymous as well, and it's being recorded, so you will have a chance to rewatch it if needed. And I'm really looking forward to this discussion. I'm sure you will have lots of questions, so please don't hesitate. I can only encourage you to use this time and ask us as many questions as you'd like. I think we can go ahead with the presentation. Thank you so much, everyone, for joining. And let me show you the presentation. Let me know if you can see it and all is okay.
Yeah, everything is fine.
Perfect. Thank you so much. Let's go then.
Thank you, Caroline. So, well, as I always say, it's a pleasure for me to have the chance of talking today to you about that amazing topic, which is one of the most frequent situations we find in the consultation. So, we are talking about options in, well, for patients that are over 40 years old and want to get pregnant. So here you will see the summary of the different parts of the presentation we are going to go through. So let's start talking about advanced maternal age. So we talk about advanced maternal age when the pregnancy occurs after the age of 40 years old. So we know that age has a very big impact in certain parts of the fertility. So first of all, we know that the age might have an impact in terms of the egg quality and also in terms of the ovarian reserve, as we know that ovarian reserve will decline as we get older. So I will show you some very quite visible pictures in a while where you can see how the age has an impact in terms of the ovarian reserve and the egg quality. But apart from that, it's also important to consider the potential effects that age might have in terms of the pregnancy. So apart from the risks related directly to the egg quality, egg quantity, we know that age can also have an impact in terms of the potential abnormalities related to the chromosomes that the babies might have. One of the most frequent ones is the Down syndrome, but many other chromosomal alterations or abnormalities are also linked to the women's age. So apart from that specific risk related to the age, we know that also the age might have an impact in terms of other complications in the pregnancy, such as an increased risk of high blood pressure, diabetes, and also premature birth. So all the risks should be taken into consideration when we are facing a treatment in patients older than 40 years old. So when we talk about the ovarian reserve, we mean the number of potential follicles we find in the ovaries. We know that we are born with a certain number of follicles, but that follicles start decreasing when women are around 35 years old, and when we get older, especially when we are older than 40 years old, there is a very deep decrease in that follicular number in that follicle number, right? So that's important. That's very important to be aware of that condition, and also to be aware of the age factor in patients that want to get pregnant. So when we want to check the ovarian reserve and we want to confirm how the ovarian reserve is, we always perform an ultrasound similar to the one that you can see in this slide, in which we are able to count how many antral follicles we can see. And apart from that, we always do measure something called the anti-Mullerian hormone. So that hormone that is secreted by antral and preantral follicle has the importance that it doesn't vary between the moment of this, depending on the moment of the cycle. So we know that doing that test and also doing a basic ultrasound, we are able to know quite a lot about the ovarian reserve of a patient. So apart from age, we also should be conscious that the ovarian reserve can also decline in several conditions. For instance, the endometriosis, which is a gynecological pathology in which there could be some cyst in the ovaries and also in other parts of the uterus, also the tubes, and also different parts of the body. So the endometriosis can typically reduce the ovarian reserve. Apart from that, if a patient has undergone an ovarian surgery, if one ovary has been removed, of course, that patient will also have a lower ovarian reserve. Same happens in other conditions, such as different oncological treatments that can also decrease that ovarian reserve. And of course, if there is any kind of genetic condition that is linked directly to a reduced ovarian reserve and also to an early menopause, those patients might typically have a lower ovarian reserve than normal. So in this slide, you can see also, as I was saying before, how the AMH decreases as we get older. So that's completely normal to have a AMH over 3, even 4 when we are younger. But as we get older, that AMH starts decreasing. That's something that happens in all patients. So with the test we perform, we are able to know the condition at this point. So it's very unpredictable to know how the ovarian reserve will be in some time, but at least we are able to know the conditions we have before starting a fertility treatment. It's also important to know that the AMH, that anti-Mullerian hormone, won't give us any information about the quality of the eggs. We are just talking about the quantity of the eggs that are still in the ovaries, but we don't have any, let's say, any test that can give us information about the quality of the eggs. But we know that the quality normally is directly related to age. So in the end, with the age of the patient, we are quite able to see and to predict the quality of the eggs, even though, of course, not all patients have exactly the same quality in the same group of age. Apart from that, as we were saying before, it's also in this part of the slide, you might see how the number of non-healthy embryos increase as we get older. As we were saying before, the age also has an important impact in terms of the potential abnormalities we might find in the embryos, because they will be having the abnormalities inherited from the eggs. So it means that everybody knows that when we get older, it's more likely to have miscarriages. In many occasions, those miscarriages, the main reason could be the abnormalities in the chromosome. So in this slide, you can see how the aneuploidy starts increasing as we get older, as well as the live birth start decreasing. At the same time as the aneuploid embryos start increasing, the chances of having a miscarriage because of embryological reasons can also increase. And that's something that it's quite visible in the consultation. That's something that happens many times. Apart from that, as we were saying, as I was explaining to you before, when we are born with a certain number of antral follicles and also a certain number of eggs. But as we get older, that number of follicles start decreasing. So as we said before, when we are around 35 years old, there is an important decrease of the ovarian reserve, and then we get when we get older, the chances of having a lower ovarian reserve will start increasing. So that's a really important thing to consider when we are starting or undergoing a fertility treatment in patients older than 40 years old. We also need to be very conscious about what we might expect from the treatment. So in which, let's say, part of everything the age might have an impact. So we know that the age in the end will increase the oxidative stress in the ovaries and also in the follicles, and in certain parts of that follicular growth and also in how the eggs are produced, it might have an impact. And in the end, the result would be a potential, like a lower number of potential eggs to be, in this case, used, and also an increased risk of having like a low also quality or a poor quality of the eggs. As I said, it doesn't happen to all patients, but we need to be quite conscious about the expectations we give the patients when they are undergoing a treatment. So when we are talking, let's say, a complex case in patients older than 40 years old, the idea is that we need to find like a good place to undergo the treatment. Of course, if possible, like apart from the basic and complementary tests to be performed before undergoing any treatment, it's important to find a multidisciplinary team where all the doctors and technologies are available for the patients to try to obtain the better results. And one of the most important things, in my opinion, is to have a close accompaniment during the procedure, because we know how difficult to deal with those procedures could be, and having the chance of being close to the patient will always help in at least making them feel as good as possible. So when we were talking about like how age might have an impact in terms of the fertility outcomes, it's important to also describe the different options we have for patients older than 40 years old. So the first step, and one of the most common ones, is the in vitro fertilization, the IVF. So with the IVF treatment, we are going to stimulate your ovaries for around 10 days. Then we will get the eggs from the ovaries, they will be fertilized, and in 5 days' time, we will get the embryos, right? So depending on how the ovarian reserve is, we can more or less have an idea of what we might expect from the treatment in terms of how many eggs we will be able to get. So as we were saying also in the previous slides, age has a very important impact in terms of the egg quality, as we have said before, also the egg quantity, but also what might happen with the embryos. So as you could have seen in the previous slides, we were also talking about how the aneuploidy, how the number of non-healthy embryos increases as we get older. So knowing that, a good option would be testing the embryos before transferring them. So this is what we call the pre-implantational genetic screening or the pre-implantational genetic diagnosis. So the main difference is that we do a stimulation, same as we were saying before. We get the eggs, we fertilize them, and before transferring the embryos, it's possible to do a small biopsy to take some cells from the external part of the embryo with the aim of testing the chromosomes and reducing the risk of having miscarriages, and also increasing the chance of having an ongoing pregnancy, considering, as we were saying before, that one of the main reasons to have a miscarriage in patients older than 40 years old is the age impact and also the age factor, as well as the, as I was saying before, the potential abnormalities that the uterus, the embryos might have regarding and related to age. So when we perform this technique, just to give like some information, so depending on the group of eggs we are talking about, the chance of having a healthy embryo will be higher or lower. So when we are talking about, for instance, patients older than 45 years old, the chances of having a healthy embryo are quite reduced. So we are talking around like less than 1% of the embryos will be healthy. So that's a good reason also to give a reason why a patient doesn't get pregnant when they're in the mid-40s, and that's something that also has to be explained to the patients. So it's important to also manage with expectations we are giving to the patients. So in this slide, you might see how the embryos develop day by day. In the first day of the egg retrieval, this is the moment when we do when we decumulate the eggs. It means that it's possible to remove the cells that are around the eggs. We fertilize the egg, we normally micro-inject the mature eggs and start doing the standard culture. So on day 1, we will see the fertilization signs, and from that moment on, we will see how the embryos start dividing, how they develop until day 5 or day 6. Those embryos are called blastocyst embryos, and this is the moment when we normally transfer the embryos in the event we decide just to transfer the embryos, or that's also possible to do the biopsy in that moment, to do the PGT as we were saying. So when we are also talking about patients older than 40 years old, it's also important, if we have the chance of having a healthy embryo, at least transfer just one embryo, to do what we call a single embryo transfer. So we were saying before that age also has an impact on the outcome of the pregnancy. So considering that information, like giving the patient the chance of having a single pregnancy, will always help her in having better results in terms of the pregnancy. So if we transfer 2 embryos with the chances of having a twin pregnancy, in the end, the risks related to that twin pregnancy will be higher, as we are talking about a patient older than 40 years old. So of course, patients in their 40s can have a completely normal pregnancy with no major problems, but if we are having twin pregnancy, the risks of related to high blood pressure, diabetes, and so will be increased. And that's something that we also need to explain to the patients, with the idea of giving them the chance of doing the treatment in the safest conditions for them. So as I was explaining before, so the IVF treatment would be a good option, but we also need to be conscious about the results we will get. So when we are not doing any kind of test in the embryos, I mean, it's true that the results in terms of the pregnancy rate will be will start decreasing when we start when we have a patient older than 38, 39 years old. That's the reason why we recommend doing that PGTD in the patients older than 40 years old, to try to increase the results and reduce the risk of having a miscarriage. So we know that around 60% of the euploid embryos, I mean of the healthy embryos we transfer, will end in a pregnancy. That's the reason why we recommend trying to reduce that miscarriage rate and increase the implantation rate as much as possible doing that PGTD. Okay, so that's a really good option for patients older than 40 years old. But sometimes, the chances of using the patient's eggs maybe are not there anymore, because several reasons, because of previous failed attempts, also because of maybe early menopause, or sometimes because of low quality of the eggs and also low quantity of the eggs. Also, as we were saying before, in many occasions we have already done several IVF treatments with no success. Also, patients with certain kind of diseases such as endometriosis might find also more difficulties in getting pregnant also with IVF. So in the end, it's true that sometimes, even though we try to maximize the patient's age, sometimes a problem of saying, okay, we need to maybe change the approach of the problem, and we need to start looking at other options such as egg donation. So the idea of the egg donation is that we are using the eggs coming from a young donor instead of the patient age. As we were saying before, one of the main factors is the egg quality, the egg quantity. So all those factors will be removed, and we are using young eggs coming from young donors, and in many occasions also fertile donors, that will give us higher chances of pregnancy. So in this slide, you can see how the success rate are according to the egg donation treatment. So the egg donation let's say the age won't have an impact in terms of the pregnancy rate with egg donation, but it might have an impact on the outcome of that pregnancy. So we know that even though the patients of 40 years old, for instance, will have exactly the same pregnancy rate as the patients that are 48 years old, it's true that the development of the embryo, of the pregnancy, could be more complicated as we get older. As we were saying before, there are certain complications directly linked to the patient's age. So that's something that we also need to let the patients know, because I mean, it's not just as easy as making them pregnant. We also need to look further and to see, or to know at least, what we might expect from that pregnancy. But egg donation could be the treatment that will give that kind of group of patients a higher pregnancy rate. So, apart from the egg donation, sometimes, especially for patients that also require a donor sperm for different reasons, patients that do not have a partner, or sometimes also if severe male factors. So sometimes another option would be like the embryo adoption. So it's like the treatment in which the patient receives a donated embryo coming from another woman or another couple. In many occasions, like the donated embryos come from also egg donation treatments, and that's the reason why the success rates are pretty high in that kind of group of patients. So we normally calculate that the pregnancy rate could be around 50 to 55%, which is pretty high. So those embryos have been previously frozen, and they have been donated by the patients or the patient that got pregnant normally with one or more of the embryos that were produced, and they decide to donate also in an anonymous way the embryos that were still frozen and they don't want to use them. So it could be also a good option for patients that maybe need adult donation treatment and prefer to adopt an embryo that has been already created. So just to finish, so as we were saying before, it's really important to have an accurate diagnosis and a specific test in terms of having a good assessment and an appropriate treatment of each patient. So not all the patients that are older than 40 years old have the same prognosis. So we also need to be quite careful in terms of the examinations we perform and also the prognosis the patient has. It's also important to examine in the best way possible the male factors. Sometimes we just get focused in the women, but we also need to be focused on the on the male factor, which is as important as the female one. And as we were also mentioning before, the IVF plus the PGTA might help in increasing the implantation rate. Also will also help in reducing the miscarriage rate and can shorten the time to pregnancy by selecting a chromosomally healthy embryo to transfer. So also for patients that are not eligible to undergo another IVF treatment, the egg donation is also the best option. In many patients with previous unsuccessful IVF attempts caused by age, low ovarian reserve, or poor egg quality. So as we were also saying before, the single embryo transfer is recommended to reduce the risks associated also to advanced maternal age, as we were saying, prematurity, high blood pressure, or diabetes. So that's something that we also should be quite, aware of that. And in our clinic, at least, we recommend single embryo transfer in all patients, considering, the age factor and the results we obtain are, quite good in that way. So as I was also mentioning in the first slides, at least for me, it's really, really important to have a personalized and tailored treatment with a really close and individual support. In the end, we are talking about a very demanding treatment. Sometimes our patients have been doing treatment before, and sometimes the results they got before weren't very, very weren't the ones we expected. So having the chance of being with them and trying to support them in the best way possible is always a really, I think at least a very positive point. So we are here to help our patients and to give them as many options as possible, even though sometimes things are not as easy as we would like them to be, but there could be like different options treatments, and we are here to maximize our patients' options. So thank you so much for your attention, and I will be happy to answer your questions from now on.
Brilliant. Thank you so much. As always, very interesting. Lots of details, lots of things to discuss as well during those 25 minutes in your presentation. So thanks a lot for sharing. And I believe you see, we have plenty of questions here already. So thanks everyone for your active participation already. Well, so let me go ahead with the first that we've got. Just give me a second. It's a bit of a longer question with some details. Let me show it to you. What would you suggest for a 41-year-old, her final IVF cycle? She has PAI1 4G polymorphism. Is any treatment needed? Her uterus biopsy test results are normal. Blood test showed me some immune issues. You can see the details here. Blood test also showed high levels of thyroglobulin antibodies and thyroid peroxidase antibodies, and you can see the details as well. Any advice here with this information that we got?
In this context, apart from the potential like clotting and immune system factor that could also be affecting, it's true that like the high antibodies against the thyroid can also play a role, but we also try to have the TSH under control. So having just antibodies is just a risk factor for certain autoimmune diseases in the thyroid. But if the TSH is doing fine, we don't like add any treatment. And in terms of the polymorphism she has, depending on the other factors, sometimes we need to add like some like heparin or aspirin treatments. But it's true that in the end, the main factor in the other round is age. So if that patient is able to get a healthy embryo if possible, the chance of getting pregnant will increase, apart from the other immune system factor that should be maybe treated or at least discussed with the patients to exactly like decide how, well, what the impact is of those factors. But the most important thing, which is like the topic we are discussing today, is the age and the potential effect it might have in this patient. So in the end, if she's able to get at least one good quality embryo, which is also important, and also a healthy embryo, her chance of getting pregnant will increase. Otherwise, even though she has like the most accurate treatment for the immune system, things won't work.
Right. Okay. Thank you so much for sharing. Thank you also for explaining. If you have any follow-ups, anything that you would like to ask, go ahead, type it in. Okay. I hope that was useful for you already as well. Now we will go for a question from Esther. Do you have any experience with IVM? I live in Germany, get treatment in New York, I guess.
I don't know why, you know, what is the, well, what those, like the IVM stands for.
I'm not sure myself,
I don't know if Esther can clarify that.
Yeah, that's okay. Let us know if you can just explain so we can have a look at this again. We will definitely do so.
Friend.
Definitely, of course. That's definitely fine. Let me just so please just let us know, okay? And we will be happy to come back to this question. And let me just go for the next one. Sorry, just give me a second. And here's the next short question. Would you suggest IVF treatment with 0.5 AMH? Not sure nanograms or picamos here, but 47.
Well, let's assume it could be nanograms. So according to the age, the chances of being successful with an IVF treatment with the patients on X are almost zero. So I would suggest at least like discussing the option of egg donation. Yeah.
In this situation, 47 age and AMH is the indication, I guess, right? This is clear. Okay, thank you so much. Let me just have a look. Sarah has another question I see here. 45 have period every month, did IVF before, and they have given us embryos, but only one pregnancy that ended early last year. Can I still try?
I mean, it's possible to try, but I would suggest in this scenario, like as we were saying before, like having the embryos tested before any other steps. So we know, as we were explaining in the previous, like in the presentation, that the chances of having healthy embryos when we get older than 45 years old are quite reduced. So it's quite likely that if the embryos weren't tested, one of the most common reasons to have that early miscarriage could have been just the abnormalities that the embryo might have. So in this scenario, is it possible to try? It's possible to try, but we need to be realistic on what we might expect from the treatment. Same as the patient before, and I mean, when we are 46, 47, 45 years old, the realistic chances of having an ongoing pregnancy in that group of age are quite reduced. So we should also start discussing other options such as egg donation, as we were saying.
Yeah. Okay. Again, thank you so much for your answer to this question. We will go to the previous one. IVM, we just got the information in vitro maturization.
I see. Yes, that's something that we don't perform it in Spain. So it's not like a daily practice. At least in Spain, it's not validated and we don't use it. We don't do it here. No, in Spain, it's not allowed. Sorry.
Of course, that's clear. So, of course, remember, in different countries get different available possibilities as well. So in Spain, it's just simply not performed. So thank you for explaining that. And let's have a look at the next question. So I guess this is, what kind of information do you provide to the patient about egg donors?
Well, according to the Spanish law, before the treatment, we can't provide any information because it's not allowed by law. Like choosing the donor the patient wants to have, but once the patient has on the treatment and she gets pregnant, the basic information we always share with our patient is like the medically important information such as age and blood type. And if the patient wants to have more information, like general information such as skin color, eye color, hair color, race, skin color, so those like general data can be given to the patient because according to the law, donation is anonymous, so it's not possible to provide any data that can let the patient recognize the donor. So with that general information is the one that we can provide the patients in the event they want to have it.
Thank you so much. So just to clarify, egg donation is anonymous. This is the reason it's not possible to share. Other countries have different rules, of course. Again,
sure, maybe pictures, but in Spain it's not possible.
Okay, thank you for the clarification. And any data, anything you can say about evidence, perhaps, or some studies? How can stress influence fertility?
Well, with the stress, it's very difficult to, let's say, measure the impact it might have. So because it's very difficult to do like let's say, a standard maybe research. And as I said, it's really, really difficult to measure the effect all the impact it might have. So it's true that stress might like affect in many different parts of the fertility, not only in the like quantity, also in the quality, also in the implantation. But to know exactly how like deep that impact could be, it's very difficult to say. So we know that it might have an impact, but we don't know in which point and also how deep that impact would be.
Right. Okay. Exactly. This is the tough situation with stress, right? We know it's definitely have an influence, but it's hard to measure what kind of influence it does have. So this is the tricky part here. Okay, thank you so much. Let's have a look, and we have another question here from Esther. And seems that I have a problem with embryo attachment. Last transfer were 3 embryos. This time, sorry, the time before 2 embryos. Okay, biopsy is negative.
Endometrial biopsy, I guess.
Okay, yeah, endo biopsy, true, yeah.
Well, it depends on the kind of treatment the patient is doing, also the age of the patient. So, I mean, just for the fact of transferring embryos doesn't mean that there could be something called a failure of implantation. So we also need to know, I mean, what kind of embryos we are transferring, if they are all the quality is good enough, either we are talking about blastocyst embryos. I mean, Depending on the situation, we can discuss if it could be like a failure of implantation or not. So just for the fact of transferring embryos doesn't mean that, the embryos that do not implant is a failure of implantation. We also need to consider what kind of embryos, and also if they have been previously tested or not. So, we should know about, more about that case to maybe give an opinion.
Makes sense. Again, as always, I'm sure we would definitely need some more details, some medical history just to properly answer, of course, this. But I do hope that it was useful for you. And let me go ahead. More questions are coming in. And let me just see. So, okay. Sorry, I'm not sure here. Here it is. Okay, sorry. So can you confirm that the babies will be normal if patient goes through three embryos? Anything you can advise here?
I guess, well, I don't exactly what
I think it's
seems, but in the event that seems that if a triple pregnancy can end in a healthy baby born, it's true that multiple pregnancies, such as triple pregnancy, has a really, really high risk of prematurity. So it's quite likely that if all the babies keep on developing, and so it's very likely that the pregnancy ends like much earlier than expected, and also the potential complications that prematurity might have.
All right. Okay. And if there is anything else you wish to add, or there's something else you meant, let us know. Okay, we'll be happy to help out, of course. And let's have a look at the next question. And just give me a second. I need to go through them. And sorry. So for a woman age 42, AMA 0.5, does it mean she's an early menopause? Does she still have any chance with IVF?
Well, to talk about early menopause, we are talking about patients younger than 35 years old that do not have the periods anymore, right? So a patient that is 42 years old and with an AMH of 0.5, that's a completely, normal ovarian reserve according to that patient age. So we can't consider that patient in early menopause first, because if she's having the periods regularly, she's not on menopause, and it wouldn't be an early menopause because of age. So in that group of patients too, that the IVF, will give, let's say, like more or less like good results, but also considering what we expect from that technique. So if she's 42 years old, if we do the biopsy of the embryos, if we do that PGT in the embryos, we expect in a group of age of 42 years old around like 12 to 14% of healthy embryos. So, that's something that we also need to know, and this is not related to the AMH, so it's just related to age. So, would it be possible to get pregnant with her own eggs? It could be possible, but we also need to be realistic of the result we will get.
Right. Okay. Thank you so much, indeed, once again. Right. Let me have a look. Okay. I think I missed one question here from Bernadette. I will go back. Don't worry. I'm 40, suffering with chronic tonsillitis, but I did not get any help from my doctor. I may need tonsillectomy. Sorry, not sure. I would like to know if it's affecting my embryo quality, or can I go for retrieval and PGT? And when I have the result from PGT, that will sort my issues.
Sure, if tonsillitis, which is an inflammation of the tonsils, is, if she's undergoing I guess antibiotic treatment and so, if there is no other problem, she can at least start the stimulation and have the egg retrieved. And then after doing, the retrieval and so, when she's back on her feet after the treatment, it's possible to maybe do the surgery or whatever they need to do in the tonsils to help her in that condition, but it shouldn't be affecting the quality at any point.
Okay, I think that's clear. Again, thank you so much, Bernadette. Hope that helped. Okay, question that we definitely receive more and more often, and we will still continue to receive those for sure. So is there a role for specific food supplements for fertility over 40?
Well, that has like, let's say, scientifically proven that there could be any changes in terms of the quality, I could say no. But it's true that many supplements, coenzyme Q10, and so are also melatonin, are supposed to have an impact in the egg quality, and also inositol. So in that way, so it's possible to take them, but we also should, know that the potential impact in terms of the quality it might have is not so big. So of course that's good to take them. Why not? And it might help us, but it's not, it hasn't been proven in all patients first. And then it's also true that, the impact it might have is not very clear at this point.
Still no evidence, right, to prove that it definitely works. And this is what we, of course, would like to have, right? Thank you so much indeed. Okay, can I still go for IVF with donor eggs when I am no longer having my period and I have scar tissues? So can IVF be successful?
Well, if she's not having the period anymore, an IVF with her own eggs wouldn't be possible because she's on menopause, so it seems the ovaries are not working anymore. And in terms of the scar tissue, I don't know if she means inside the uterus, if there is something like maybe like what we call an Asherman syndrome, that is like a pathology where there are scars in the uterine cavity. So depending on how severe that potential Asherman syndrome is, sometimes it would be, well, there could be some technique that can be done to increase and to improve the result, but sometimes that pathology could be quite challenging for us, and sometimes it's very difficult to help a patient get pregnant in that condition.
And that patient added, I'm 46, and she actually asked about IVF with egg donation. And in this case,
yeah. So with egg donation, there's also going to be much better. But as we said, it would be important to also check the uterus in the best way to know how likely it would be to get pregnant, depending on the status of the uterus.
Okay, and we have a very similar question from a different patient. So if a woman is in her 50s in menopause, and can she still do IVF with egg donation as well? Is it possible?
Well, depending on what she means in her 50s, and also depend on the country. In Spain, for instance, the limit normally is like 50 years old. So at least here we don't do too many patients older than 50 years old, even in our eggs, not because of the results, it's more because of the risks of that pregnancy and the potential complications that the patient might have when she gets pregnant if she's in her 50s. So it depends on the country. I guess that maybe in other countries it could be an option, but in Spain the maximum would be 50.
50. Okay, so it's important to provide, like, if you're 50 or 51, 52, that changes things as well, right? So it's important to mention that. And do you transfer poor graded 5cc or aneuploid embryos in your clinic, or do you discard them by default?
Well, in regards of the aneuploid embryos, according to the Spanish law, it's not possible to transfer them, so we just exclude them. And regarding the poor graded embryos, it depends. So a blastocyst 5cc normally wouldn't be implanted at any point. Of course, if it's just the only embryo a patient has with her own eggs, and she doesn't want to do the pre-implantation genetic screening, and she wants to transfer that embryo, of course, we can give her the opportunity. But of course, generally speaking, of course, with egg donation, we wouldn't transfer that embryo for sure. And with IVF, it depends on the condition, but normally I don't remember transferring any like embryo graded like so low. But of course, it depends on the case.
Okay, thank you. And how about discarding of the embryos? How does it work?
Yeah, so it depends on the classification that normally the biologists do in the laboratory. So if the embryos are graded CC or DD or CD or so, those embryos are normally discarded. So it depends on the quality, and also if they finally do the PGTA. Of course, if they have been classified as aneuploid, we always discard them.
Of course. Okay, thank you for the clarification. Important to make a note of that as well. So thanks a lot as well for that. And let me just go. Some more questions are in, so we will be slowly finishing. But if you have more, keep them coming. We still have time, so please type those in. And let me just go to the question about about stem cells. What about stem cells to the ovaries? Can that restore some equality?
Well, it's true that we have been using not stem cells, but we are using the plasma-rich platelet in certain group of patients, but they are like still experimental techniques first, and then they have to be performed in young patients. So in the end, we don't have with the stem cells, there is no so much well, experience for that. And it's that we are not using it, but for the PRP, the plasma-rich blood, we are using it, but for young patients with a really low ovarian reserve. So in the end, it's very difficult to restore the, let's say, environment and the conditions the ovaries had maybe 10 years ago. So even though we try, as I said, to maybe stimulate the ovaries in the best way possible to try to have, as good quality as possible, sometimes we also need to be conscious about, the impact of age, and sometimes very difficult to reverse that impact.
Right. Okay. So you perform PRP, and you said that for younger patients, what exactly you mean? What kind of range
So
is
with
this?
young patients like below normally 35 years old with a low ovarian reserve. Yeah, it's the
Mhm.
criteria we normally follow.
I guess it's still like not evidence-based, right? We still
Exactly,
lack
it hasn't
evidence.
shown at least like really like good evidence of like improving the results. Because it's true that we have done like quite a good number of PRP infusions, and we have had all the results. Patients with better response in the upcoming cycle, but some others that we then find any difference.
That is the reason you focus on those younger patients, yeah?
Exactly,
So
because it's the one that I mean, we can't say that they have an age factor. So it's just maybe like the oxidation they have in the ovaries. So we try to reverse that oxidation or, whatever is happening in the ovaries. But with older patients, we know that the main factor is age. And to reverse that factor is almost impossible. Yeah.
right, of course, this is the hard part, definitely. Thank you so much indeed. I think that we had done lots of events on PRP, of course, as well, and it's still something that I think lots of people are asking about, which
Yeah.
is obvious, of course, but it's still something that we need to repeat. Remember, it's not like evidence. We still lack evidence to just confirm that it's like working for everyone. All right, thank you so much. One more question we did receive in the meantime, so let me go to that. Sorry, I kind of, yeah, sorry, here it is. Do you advise day 6 embryo transfer if on day 5 the embryo did not reach expanding blastocyst stage?
Yeah, I mean, if the embryo on day 6 has expanded and has a good quality, I would suggest transferring it. So I know that many patients think that the day 6 embryos do not have any chance of implantation. So I know that he has quite a, let's say, not very good opinion in terms of what the patients think. But it's true that we prefer day 5 embryos, that's completely true, but in many occasions we have to transfer day 6 embryos and the success rate are also good. So we can choose between day 6 and day 5, I would say good day 5. But if the embryos are not good enough on day 5, waiting for one more day can give us also the option of having an expanded blastocyst and transferring it then.
Okay, brilliant. Thank you so much for the clarification. It's really important to note that yes, day 6 embryo transfer is still an option and still a successful. So it's really I'm really happy that we were able to also answer your question. It's really important to note that. And I believe that was our final question. I don't see more questions here, but obviously, as you know, if you have any other questions, you can definitely get in touch with Clinica Tambre directly, and I'm sure they will be more than happy to help you out. And if you have any other questions, or you can still type us, but I guess we will be finishing for today. Thank you so much. Very interesting session. Lots of questions as always. Thanks a lot for those. We are simply here for you. So I'm really happy that we were able to discuss this topic and answer so many questions from you. Dr. Marban, thank you so much. Any final words before we finish for today? It was lovely to have you back for sure.
Yeah, as I said before, I'm more than happy to have the chance of sharing with you this small part of time, and also to have the chance of answering the questions of our attendants. So I'm more than happy to be here again today with you.
Looking forward to some more events with you for sure. As you know, we will be back with some more and more events. We are back next week. We will talk about mosaic embryos, but there are plenty of topics that we will be discussing in July. So stay tuned. You can go to my IVFMsters.com website. You will find all upcoming events right there. There are plenty of new events, different events, Q&A sessions, but also success stories, patient meetings, ask your doctor events, ask your embryologist events. So you can choose plenty of topics, plenty of various fertility specialists. So I'm really happy to be here and to help you out, even if a little. So thank you so much, everyone. Have a lovely evening. Dr. Marban was our guest today, Dr. Marban from Clinica, fertility specialist at Clinica Tambre in Madrid. Thank you so much for joining. Have a lovely evening, everyone, and see you soon. Okay, take care. Bye.
Take care. Thank you, Caroline. Thank you.
Bye.